Welcome to PAPERI Bright Minds, where we celebrate the pioneers shaping the future of genomics, precision medicine, and childhood cancer research. In honor of International Women's Day, we are proud to feature Dr. Mary Relling, a world-renowned expert in pharmacogenomics and pediatric oncology. Dr. Relling has dedicated her career to advancing precision medicine for childhood leukemia, revolutionizing how genetic insights shape cancer treatment. As co-founder of the Clinical Pharmacogenetics Implementation Consortium, CPIC, she has played a key role in integrating pharmacogenomics into clinical practice worldwide. Through decades of research, leadership, and mentorship, Dr. Relling has inspired generations of women in STEM, paving the way for the future of genetics, oncology, and personalized medicine.
Hello everyone, and welcome to the PAPERI Bright Minds Series. In this special edition, celebrating International Women's Day, we spotlight exceptional individuals shaping the future of genetics, genomics, and precision medicine across Africa and globally. I am Wafa Rashid, chair and founder of PAPERI, and I am honored to have you join us today for an inspiring conversation with a true pioneer in the field. Today, we are privileged to welcome Dr. Mary Relling, a pioneer in pharmacogenomics and a leader in personalized medicine. Her groundbreaking research has revolutionized leukemia treatment, making therapies safer and more effective for children worldwide. Her leadership at St. Jude Children's Research Hospital has set a global standard for integrating genetics into clinical care. Dr. Relling is an emerita member of the Department of Pharmacy and Pharmaceutical Sciences at St. Jude. She earned her Bachelor Science degree from the University of Arizona College of Pharmacy and her doctoral degree from the University of Ottawa College of Pharmacy. Her postdoctoral fellowships included work with Dr. William Evans at St. Jude and Dr. Ernest Meyer at the University of Basel. She joined St. Jude as a faculty member in 1988 and served as the chair of the Department of Pharmaceutical Sciences from 2003 till 2020. He also held positions as a professor at the University of Tennessee in the colleges of Medicine and Pharmacy. Dr. Relling is a co-founder of the Clinical Pharmacogenetics Implementation Consortium (SPEC) and has published over 450 original scientific manuscripts. She was elected to the National Academy of Medicine in 2009. Today, we have the privilege of hearing her insights on pharmacogenomics, precision medicine, and the role of women in science. Dr. Relling, it's truly an honor to have you with us today. We have many questions regarding many aspects. Let's start with your career and research journey. So my first question, what inspired you to pursue a career in pharmacogenomics and pediatric oncology?
Hi, thank you. It is such a pleasure to be with you. This is wonderful. So let's see. I guess I started as a pharmacist. I realized that it was frustrating to make recommendations on drug therapy because sometimes we didn't have good enough data upon which to make our recommendations. So I early on recognized that the research database needed to be improved in therapeutics. And so that's what made me want to go on and pursue a career in research. And I also always very much love clinical care and taking care of patients. So I was always conflicted about, I didn't want to give up completely my link to patient care, but I also saw that it was difficult to do both. So I'm very lucky that I ended up at St. Jude Children's Research Hospital in Memphis, because many times in academic pharmacy, faculty members have this terrible conflict of they have three major areas that they have to contribute to. They have to contribute to teaching, they have to contribute to research, and they have to contribute to clinical care. In the US, that's the way most universities are associated with a clinical practice also. But with St. Jude, the good thing was that We definitely had to do research, and we had a strong commitment to clinical patient care, but we didn't have to do very much didactic teaching if we didn't want to. So for me, I chose that I would like to focus on research and patient care. Also, in terms of what area of therapeutics, I love pediatrics because I think it's very easy to be satisfied making a child's life better. To me, sometimes when you're taking care of very old people, it's a bit depressing. They often are ready to leave. They're ready to go. They don't care about their health care or their medication. So I prefer taking care of children than taking care of older adults. And I loved oncology because it's so critical to get drug therapy correct. If you give too much of an anti-cancer drug, then you may have unacceptable toxicities. And if you give too little of an anti-cancer drug, then you won't cure the cancer and the patient may die of their original malignancy. So I think it's more interesting to work in an area of therapeutics where it's very important to get the drug and the dosing correct. So that was why I loved pediatric oncology. And so I decided after my education at University of Arizona and University of Utah to do research training, as you said, at St. Jude Children's Research Hospital. And just at that time, pharmacogenetics was getting more attention. Everybody knew that the Genome Project was underway. It was still 10 years away from its final conclusion, but it was clear that we were going to make progress on sequencing the human genome. So it seemed like a great time to try to learn about pharmacogenetics and to see if it was an important determinant of anti-cancer drug outcome in children, especially. I liked working in children with leukemia. So that was a great time to go do a postdoctoral fellowship with Dr. Ursmeyer at the University of Basel in Switzerland. They had just cloned the gene called CYP2D6. It's now called CYP2D6. It used to have different names. So that's the gene that's responsible for metabolizing many, many medications. It started with debrisequin and spardine, but it affects beta blockers and narcotic analgesics and many important drugs. So that was a great time to be in his laboratory, and we began very even in the late 1980s, knowing that the genomic revolution was coming. We started collecting a blood sample for germline DNA from every child with cancer at St. Jude. Because at that time in the cancer world, there was a lot more interest in looking at DNA of the tumor than there was at looking at DNA of the host. Mm-hmm. And so it was really good that we did that, because then we had all of that DNA stored. And when a few years later, the Human Genome Project was completed, the tools of molecular biology were very easy to apply. Most people didn't have the DNA samples, but we did. And so not only did we have DNA samples, but we had long-term follow-up on those children, which is another thing that most places that treat cancer patients don't do a very good job of following those cancer patients long into the future. So they don't know what the overall long-term consequences, the side effects, and the late effects of chemotherapy and radiation are. But at St. Jude, we follow every patient almost forever. So we know if they develop a second cancer, if they develop late osteonecrosis, if they develop heart disease later, if they develop recurrences of their cancer. We have all of those phenotypic outcomes collected. So that really set the stage for us to do a lot of our own pharmacogenomic research into, does genomic variability contribute to adverse outcomes of children with leukemia?
Okay, so the concept of biobank you introduced early in the late of 98, as you said, in addition to long-term follow-up of patients.
Yes.
Yes, this is great. Okay, my next question, was there a specific moment in your research that really shaped your approach to personalized medicine?
Oh, I don't know. I think, I mean, I remember when I was still a student at Utah, we had a woman who was admitted to our veterans hospital. So that was unusual because 95% of the people that are treated at the veterans hospitals in the US are men. But she was a woman and she had rheumatoid arthritis and she took methotrexate for her rheumatoid arthritis. And instead of taking the methotrexate um, for one dose every 12 hours for 3 doses and then stop and not start again for a week, she just kept taking her methotrexate every 12 hours for
Mhm.
multiple days at a time. And so that little bit of an overdose, which was just 5 or 6 days of continuous methotrexate instead of one day, was enough to put her in the ICU. She developed a terrible infection and mucositis, and she died from the complications of that. And at that time, I realized that I didn't understand methotrexate pharmacokinetics. I didn't know anything about how to measure blood levels of methotrexate. Should we get blood levels of methotrexate in that patient, or was it too late, or would they be undetectable? Should we give her leucovorin rescue? Was it too late? If we did give leucovorin rescue, how much would we need to give? What's our goal? What's our therapeutic goal? So it was a very clear illustration of how we need to understand how to individualize therapy in individual patients to deal with rare but very serious complications. And that's really the reason that I went to go work at St. Jude, was because Dr. Evans, who had been at St. Jude, had written the chapter on methotrexate pharmacokinetics.
Uh-huh.
And when I subsequently went there and I became a fellow, I did methotrexate consults every day for basically for 38 years. So um, it taught me it's important to develop expertise in specific areas. I'm not going to be the world's expert on every drug and therapeutic drug monitoring for every drug, but I need to learn how to do therapeutic drug monitoring for the patients that I see and become really expert in them. And also in terms of just understanding how we have to look at inter-individual variability. So in fact, I became chair of our pharmaceutical department, and I did that for almost 20 years. And the goal of our department was very, very narrow. It was to elucidate the importance of inter-individual variability to drug response and to try to utilize that information to improve therapeutics for our patients. There's many, many important areas of pharmaceutical sciences, right? There's formulation science and distribution science and coming up with new methods of delivery of drugs. All those are very important, but we were a very small department and we couldn't do everything. So we focused on this one thing. How does inter-individual variability in drug response affect inter-individual variability affect drug response? And of course, then you learn that there's many things, right? There's drug interactions, there's kidney function, there's liver function, there's age, there's concurrent illnesses, so the presence of serious anemia or pre-existing gastrointestinal problems or pre-existing infections. And another source of variability is genetics.
Yes.
And so we always try to remember it's not necessarily the most important cause. between patients. It's just a source of variability that's very easy to measure now because you can get that one DNA sample from a patient and use it for the rest of their lives. And it's very inexpensive to do discrete DNA-based genetic tests that can give you a very clear result. Is this person's genetics normal or not with respect to that gene? So it's a fun area to work in because it's so clear. It's not necessarily the most important area, and we've estimated that we think that only maybe about 15% of medications are very, very strongly affected by genetics. Maybe only 15% of medications are so strongly affected by genetics that we should use genetics in deciding how to prescribe those drugs. But for that 15% of drugs, it's very important. But that doesn't mean we can ignore all the other causes of variability, like just straightforward pharmacokinetic variability, drug interactions, and so on.
Great. Okay, so my next question, what were some of the key challenges you faced as a woman in pharmacogenetics, and how did you overcome them?
You know, I have never had a challenge in my career that I
Really
thought
great.
was because I was a woman.
Oh, okay, so um, as I said in the introduction, you joined St. Jude in 1988, so you have been part of St. Jude Children's Research Hospital for decades.
Yes.
What makes St. Jude a unique place for scientific breakthrough?
Yeah, it's so basically it was a hospital that was started by a philanthropist, an entertainer. He was an actor and comedian in the 1950s named Danny Thomas. He had a hard time in his life when he was in his 30s, and he prayed to the Saint Jude of hopeless. He was the patron saint of hopeless causes. He had no money, and he made a prayer, and he made a deal with the saint in his mind, and he said, "Lord, if you will show me the way, I will build you a shrine." And he eventually he became very successful, and he never forgot that promise that he made. And so he went to his local bishop, and he asked, "What can I do? I told God I would build him a shrine. What am I supposed to do?" And he said, "Well, don't build a shrine, build a hospital, and build it in the south of the United States, which is not as developed as the East Coast and the West Coast, and make sure that it's available to everyone, no matter their color, religion, or really importantly, or their ability to pay." So in the United States, most healthcare is still basically profit driven. And so even though we have a lot of government subsidies for healthcare, most of those hospitals have a very strong incentive to try to make a profit. At St. Jude Children's Research Hospital, we get tremendous donations from the public to support the hospital so that our patients don't have to pay, and to support our hospital so that we can do research that wouldn't otherwise be done. And so it's really that monetary support that St. Jude gets from the public. There are millions of people who give $30 a month, $20 a month, and that's the majority of the money that St. Jude gets. So what it allows you to do as a scientist, you know, so I was a department chair, I had 10 faculty members working for me. They were still expected to bring in grants to fund their own research programs, partly because it helps to have the extra money, and partly because the process of getting a grant in the United States, and I'm sure where you are too, it's very competitive. So it's a bit of an imprimatur. It's a bit of a sign of the good quality of the research if an independent review committee says, yes, this should get money.
Yes.
So about 40% of the money in my department to do our research, we brought in through grants, but 60% came from St. Jude. And that means it came from all those people who donated their money. And so it allows you to establish very secure and stable funding. So in much of the world where there's academic research, your funding goes up and down, up and down, up and down, right? You lose money, you gain money. When you gain money, things go great. Then you lose the money. You can't do any research for a couple of years. You may have to let go of staff. You may lose people to other institutions because they're not happy if it's not a stable situation. And you can fund, a really important thing that St. Jude did was it took some of that money and it didn't give it to people like me. It didn't give it to my department. It put the money into common research resources. So we had a common animal facility. We had a common statistical resource, common flow cytometry, common electron microscopy, common LC mass specs, analytical chemistry cores. They were called core laboratories, and there were maybe 20 of them. Common clinical research office who helped with designing all the protocols, hiring research staff to run databases, quality control people. All those people are very, very expensive for any one individual research to pay for. But if they're spread among many departments, of course, it's more cost effective. And it's also better because things become better when you have a critical mass, right? The quality becomes higher. When you have a lot of people who are doing mouse research, you get the best mouse facility in the world. Yes. When you have a lot of statisticians who are providing input into different clinical trials, yes, you get the best statistical resource in the world. And so that was really one of the things that was fundamental was just money to support the common elements of research. And then the other really interesting thing they did at St. Jude is the physical facilities. So we had many buildings, and the hospital beds were probably spread in 2 or 3 buildings. The clinic spaces were probably spread in 2 or 3 buildings. Then all those academic departments, pharmaceuticals, surgery, biochemistry, infectious disease, pathology. There were 20 academic departments, and we were all mixed together. So everybody ate in the same big cafeteria every day with the patients and their parents. So it was very forward thinking that this entertainer, Danny Thomas, thought of 80 years ago. People need to interact. They need to mix. They need to mingle. When you're in the elevator, when you're getting a cup of coffee, when you're going to the cafeteria to get lunch, when you run into people, you may spark a conversation to start a new area of collaboration, and that wouldn't happen otherwise. So many, many people try to foster that those interactions, but St. Jude just really did it. They really, they actually did it.
This is great. So sustainability of fund, a very good infrastructure.
Yeah.
With you. Yeah, this is great. Now let's focus in another area, in precision medicine and pharmacogenomics.
Yeah.
You co-founded the Clinical Pharmacogenetics Implementation Consortium, SPEC.
Yes.
How has SPEC shaped the integration of pharmacogenomics into clinical practice?
Yeah, I think it's really helped. I started it with Terry Klein at Stanford in 2009. And now Terry Klein co-run CPIC with my colleague, Dr. Kelly Caudle.
Yes.
She actually works at St. Jude.
Yes.
So it's really operating much the same. It's been operating the same way really for 15 years now.
Mhm.
And yeah, I think it really helped because I started CPIC partly selfishly because we wanted to start implementing pharmacogenetic testing at St. Jude. And part of the rationale was we were getting to have whole genome sequencing done on our patients for not very much money.
Mhm.
So as part of their cancer treatment, we would sequence their cancer cells and we would sequence their host cells.
Yes.
And most of the doctors were only interested in the cancer cell DNA, but of
Mhm.
course we were interested in the host normal DNA. And so once you generate all of that information, I didn't order a specific pharmacogenetic test for this cytochrome P450 or this HLA gene or TPMT, but I have all that information incidentally because the genome is already done.
Mm.
So we decided that this kind of problem will become more and more common. Patients will get DNA sequence done, either on their own, by their cardiologist, by their oncologist, by their pediatrician, by a direct-to-consumer lab. More and more patients have DNA sequence available, but clinicians don't understand which DNA sequence variations are so important that it would be unethical for them not to use that information when they're prescribing drugs. Right?
Clinical utility.
So we decided if you can get the genetic information put together, it's freezing for me, so I hope you can still see me.
Yes.
Okay. Then how do you tell clinicians what to do? Can you make a link between the genetic test information and, let's say, clinical decision support, a very specific recommendation to give to each prescriber based on their patient's DNA and the drugs that they are given? So we felt like there'd been 50 years of problems with people trying to decide, must I order a DNA test before I prescribe this drug, thiopurine? Must I do that? And then you have to get into all these questions of cost effectiveness. Is it more important to order a DNA test, or is it more important to get an X-ray of the chest? It comes into all these monetary cost effectiveness decisions that is very difficult, and it differs for every country. It differs for every practice. Where is the best place to spend your money? I don't know. But if you have the DNA information, what should you do with it? So that was the basis of CPIC. And we decided we would have to tackle it very, very granularly, one gene drug pair at a time. And for every gene drug pair, we had to get experts who understood the gene, the drug, the disease that you're treating, and the side effects that might occur if you get it wrong. So that's why we decided CPIC. And we started with, I'm looking at my little list here, we started with the gene TPMT and the medications thiopurines. Then we very quickly moved to CYP2C19 and the antiplatelet agent clopidogrel, CYP2C9 and VCORC1 and the anticoagulant warfarin. So we started with easy gene drug pairs. CYP2D6 and codeine. I mean, it's a great example of, if you give a patient codeine and they are a CYP2D6 poor metabolizer, they cannot possibly get any pain relief from that drug. There's no way. It doesn't get anabolized to morphine, and that's the only way that codeine has an analgesic effect. And yet codeine was still one of the top 10 drugs prescribed in the world when we started. Nobody was checking to see what is your CYP2D6 gene status before they made the decision to prescribe codeine. And we were saying, that's not right. If you know that somebody is a CYP2D6 poor metabolizer, we should make it easy for clinicians to see how they should change their prescribing based on that information. So that's what we did. That's what we're doing. That's what we're continuing to do. There's no shortcut. It's very, very labor intensive. Every guideline takes about a year to complete. And so it's very, very slow, painstaking work. But I think, and the last time I looked, I did a review of the literature of all papers that were published worldwide on that mentioned the words implementation and pharmacogenetics. 2/3 of the papers referenced CPIC. Okay. So I think it's had a very, very big effect. Everybody that's doing clinical implementation of pharmacogenetics in the United States definitely uses CPIC, and our intention is to have them work internationally. So we always have international authors on every guideline. We try to include drugs that aren't necessarily available in the United States. But yeah, it's just, it's very, very difficult, hard work that does not get enough money. So, because that's much bigger than St. Jude, that applies to all drugs, all diseases worldwide, not just for pediatric cancer patients. It's a much bigger scope of work than falls under St. Jude. And so we've been able to get some money from the National Institutes of Health through grants since 2010 to help support that work. If we had more money, we could do it faster and better. So it like anything else, it takes time and money.
This is great. My next question, can you discuss the role of genetics in leukemia treatment and how it has transformed over the years?
Yeah, so in leukemia treatment, yes. one of the poster children, the best examples of pharmacogenetics is the variation in the gene TPMT and 6-mercaptopurine, 6-thioguanine, and azathioprine, the first two of which are used to treat all lymphoid malignancies. And subsequently, we added a second gene called NUD-T15. That was a very interesting example because that was only discovered when it became more widely studied in non-European populations and actually non-African populations. When it came to be studied in Asian populations, then it was clear that there was a pretty high frequency of genetic defects in T15, which is just as important as TPMT. So now many places, including St. Jude and all centers in the US that treat leukemia, test for those two genes before you get the first dose of thiopurine drug. Because if you don't know somebody's status and they are a complete poor metabolizer, they can die from toxicity within just a couple of weeks. The other gene that we use in pharmacogenetics in leukemia, there's supportive care drugs, like I mentioned, for pain relief, CYP2D6. Also, CYP2D6 is important for, not CYP2D6, CYP2C19 is important for the antifungals, like voriconazole. So those few genes we test, well, now we test all of these genes in every patient, but for leukemia patients, we think that those genes should be tested up front. G6PD is another gene that's very important, has worldwide implications because, of course, it's important for primaquine and some anti-malarial drugs, but it's very important for resburicase, which is given to patients with hyperuricemia with newly diagnosed leukemia. And that is another gene that we test for every leukemia patient before we start therapy. A lot of the anticonvulsants that we use are affected by HLA genes, and so we also test for them. We sometimes have patients with leukemia who need nonsteroidals, and we test for CYP2C9. So several of these single gene tests are really important for patients with leukemia. But of course, the main body of research on genomics in leukemia is looking at the genomics of the tumor cells themselves, the somatically acquired genomic defects that help drive tumorigenesis. They help, determine what turns a normal cell into a leukemia cell. And those have been very, very well delineated by many of my colleagues at St. Jude and elsewhere, using genome-wide tests to further subcharacterize leukemia. So whereas we used to just talk about acute lymphoblastic leukemia, now we know that's probably about 20 different diseases based on the genomic profile that you have at diagnosis. And some of those findings are helping to find new therapies that are specifically targeted to those genomic defects. So a lot of the newer anti-cancer therapies, especially tyrosine kinase inhibitor type drugs, can work in specific forms of leukemia that have those somatically acquired defects. So it's really, unfortunately, a very complicated picture where there's a lot to track in every newly diagnosed leukemia patient's genetically. You need a set of genetic results to describe what the tumor itself is at diagnosis and if it occurs at relapse. And then you need to also have the host genome characteristics classified in such a way in the medical record that they're actionable, right? So even at St. Jude, we sometimes still have this disconnect of for the germline pharmacogenetic variants, we do a very good job of making those discrete, actionable results in the medical record to which you can link clinical recommendations. You could link an alert that says, don't treat this patient with the normal dose of 6-MP, 6-mercaptopurine. They have a defect in TPMT and a T15. In the same way, you could have an alert that says, this patient has Philadelphia chromosome positive acute lymphoblastic leukemia. They need to receive dasatinib or imatinib as tyrosine kinase inhibitors for their leukemia. And likewise, if the patient doesn't have one of those actionable defects in tyrosine kinases, they probably shouldn't be receiving a tyrosine kinase inhibitor, or at least somebody should check and make sure. So sometimes those somatically acquired genomic variants that are very important for genomic therapy are hidden in the medical record in a laboratory result that might be a PDF file with no discrete elements, no way to target and drive clinical decision support off of the findings. So there's still a lot of work to do to make sure that we take all of the genomic findings that we're learning how to act on and track them in our medical records in a way that makes them useful to clinicians, not only tomorrow, not only the day after you get the result, but 10 years from now, 20 years from now. So those are some of the really big challenges everybody's having, I think, in implementing genomic medicine in the real world.
Thank you so much. Your research has led to personalized drug therapy for childhood leukemia. What are some of the biggest breakthroughs in this area?
I'm sorry, in what? In
Your
treating
research,
childhood leukemia?
yes, personalized drug therapy of childhood leukemia. Yes. What are some of the biggest breakthroughs in this area?
Well, you know, for me, they're usually um, not very not very not necessarily so interesting or intellectually stimulating, right? One of the most important things we did was to prove that you should not use enzyme-inducing anticonvulsants for a patient while they're getting chemotherapy, because enzyme-inducing anticonvulsants that induce liver enzymes like liver P450s, like phenytoin and carbamazepine and phenobarbital, those drugs are very, very dangerous, really, because they increase the clearance of all the anti-cancer drugs like cyclophosphamide and cytarabine and tonipicide and glucocorticoids. So after we showed that those enzyme-inducing anticonvulsants were very dangerous, we don't use them at all anymore in treating leukemia, and they're not permitted. We have to find another anticonvulsant to use in patients. Some of the, I guess the work that we did with TPMT and T15 was very important to show that we could individualize thiopurine therapy, decrease the dose of thiopurine therapy in patients who have a genetic defect, but not compromise their desired anti-tumor effect. Something very simple that we did really recently was not really by our research, but by writing the CPIC guideline for G6PD. You know, there's many drugs that are putatively associated with G6PD, like over 40 medications have warnings from European drug agencies, Japanese drug agencies, from the World Health Organization, from the FDA in the United States. There were more than 40 drugs that were considered dangerous to give to a patient with G6PD deficiency. But we found by carefully looking at the literature that some of those most common drugs were not actually impacted by G6PD deficiency. So that included sulfa drugs like sulfamethoxazole. And so now, when we have a patient who has G6PD deficiency, up until a couple of years ago, they were prohibited from receiving sulfamethoxazole trimethoprim, which is a very commonly used antibiotic. And if they needed to get prophylaxis against a pneumocystis nosocomial infection, we would use inhaled pentamidine, which required the patient to be admitted to the hospital, be hooked up to a nebulizer. It was very expensive. It had a lot of toxicities. It was difficult for patients. Now we don't do that. If a patient has G6PD deficiency, we just keep using sulfamethoxazole. So that was about 10% of our patients that were undergoing a very expensive, unpleasant, more dangerous therapy that no longer have to get that more expensive, dangerous therapy, just because we learned better how to use the drugs that we already have at our disposal.
Yeah, okay, thank you. I think you answered this question regarding what are the biggest challenges in implementing pharmacogenomics into routine clinical care today. You said that implementation of pharmacogenomics differ between countries, differ from country to another. But I want to hear from you if there anything you want to add.
Yeah, I guess that it is difficult to implement for many reasons. I mean, there's a general feeling sometimes that there's not very much interest in optimizing drug therapy. It's boring. If somebody's an expert in treating cancer, they think that they know how to do everything and they don't want to think about changing their practice. So I think in general, there is a hesitancy to accept the importance of optimizing drug therapy.
Yeah.
Many clinicians think it's just boring and not important. And pharmacogenetics is actually an easy way to do that, but they don't necessarily see that. So yeah, I think there's a huge challenges with how to continue to act on these test results over the life of the patient. It's unusual to have a test that's a lifelong test, right? Once I test your genes, your genetics, in general, it's not going to change for the rest of your life. I could take you as a baby and do your full genetic profile, and that would be very informative for the rest of your life. But how would you keep that information so that it's available to every clinician you see for the rest of your life? See a pediatrician as a child, see a OBGYN in your 20s and 30s, you see specialists, you see internists, you see surgeons, you go to emergency rooms, you travel, you go from state to state or country to country. How do we make that test result easily accessible by every clinician who's going to treat you for the rest of your life? We have not figured out how to do this.
Okay, now let's discuss or have questions regarding women in science and leadership. Despite making up nearly half of the global workforce, women represent only 30% of researchers in STEM fields. So, from your perspective, how has the role of women in pharmacogenetics and clinical oncology evolved over the years, and how we can bridge this gap?
Yeah, I think like you said, it maybe it's 30% now, but it was probably 5% 50 years ago, right? So it's increasing. And so I'm probably naive, but I think that there's no reason to think that women shouldn't be good, right? At leadership in science. I don't know of any biological reason to think that that should be a problem.
Yeah.
So I worry that if we talk about too much improving opportunities for women,
Yeah.
why do we want to improve opportunities for women and not also improve opportunities for men? We want to have the best people doing work, right? We want it to be the best. And sometimes that's going to be a woman and sometimes it's not. Depends. It depends on the situation. And so I worry about promoting it too much as a cause. There is a downside of promoting it, I think, because the promotion implies that it's necessary, that there's some reason that I need help being remembered to people who are making the hiring decisions. I need help when I'm getting my grant. It will help to remind people that I'm a woman. Every time you do that, there's a little bit of subliminal, well, why does this person need special consideration? So I worry about it. I don't know. What do you think?
You are right that there is no biological barrier, and diversity is very important in this field. So, if this person, man or woman, um, is good for this position or for this grant, it's okay to go. There is the opportunity based on the skills, the ability to achieve the task in the proper way as expected.
Yeah.
Yes, you are right.
Yeah.
You have received numerous prestigious awards and honors. What advice do you have for young women looking to lead in STEM and medical research?
I think I give the same advice to a young woman as to a young man, and that is find somebody good to be your mentor. Find a place to train where there are lots of good people. And I do believe when I was young, sometimes I thought I want to be someplace where it's small, and that'll give more attention to me. But I think when I've gotten older, I realized that that's not the right attitude. I learned a lot more by being in an atmosphere where there's lots of smart people. Maybe you have to fight a little bit more to get attention, but because there's a critical mass of smart people, you learn more from working with the best people than getting a lot of individual attention. The other advice somebody gave me when I was young, Linda Strand, she was at Utah, and she taught us, if you're going to do research, the most important thing is that the question is important. The research question has to be important. It's not that can overcome everything else. And it's difficult. Again, sometimes when you're young, you choose a research project because it's simple. You choose a research project because it's feasible. And when you're young, you may have to do that. You may have to do that in order to learn techniques. But once you get out and you're trying to become established and you're trying to become a leader, choose your research question very carefully. Make sure that when you write those aims for your first grant, you can easily write a section saying, why is this important to answer this question? If it's not important, then it won't work. It won't be helpful. And it might be a waste of money. And it might not help you get ahead in your career either.
Yeah.
Now, the other thing, which maybe I don't think it's in conflict, but I think it's really true, is to be willing to help with projects when you're young
Yes.
without getting credit, right? I know there's a very famous quote that you can't imagine what we can do if we don't care who gets the credit for it.
Mm-hmm.
And so there are projects like that where sometimes the upside of just helping with something important, where again, you might be a very small piece, your name might not be on the paper, your name might not be on the protocol, nobody ever says thank you, but if you are helping get something done, like a research protocol, like helping your mentor write a grant, like helping to implement something important that's bigger than you, for which you get no credit, I think that always helps in the long run, because people will start to see, oh yeah, that person is a doer. That person likes to get things done. That person knows how to get things done. And you may not get credit at the beginning, but eventually you will get credit in the long run. So I think that's very important too. And that's, for me, that's why it's been nice to have a career that has both patient care and research, because sometimes I was doing things more for patient care and they really didn't have anything to do with the research. But because they were so helpful for our patients, the other physicians who took care of those patients, the hospital, the nurses, everybody's grateful that you're doing something to help patients, and they may help you do your research 5 years later, you know? Yeah. And so I think the same kinds of things can happen if you're not in a clinic. You can just be helping people with a bigger project without worrying too much about the credit at the beginning. It's difficult because eventually to get promoted, you have to get credit.
You mean that, let's say this is a training, but with certain limit. I mean, the first, second one with no credit, but consider it as a training for you.
Yes, as training. Yeah, that's true, as training. And also, if it's in the right place, as a place to get people to respect you.
Yes, yes.
I mean, many times I don't think young people don't understand. One of the most important things is you must have 6 people who will write you an excellent letter of recommendation. You have to have somebody write you a letter of recommendation that says, that girl, she knows what she's doing. Boy, did she help us out. Hard worker, here in the early in the morning, leaves late at night, always helpful, gets along with people, good communicator. You need people to write those letters.
Yeah.
And sometimes young people don't think enough about, they've got to make these personal relationships. It has to be real. I mean,
Yes.
sometimes I have had students who are not, they're not detail oriented enough. They're not accurate enough. I ask them to summarize the literature on something and they give me an incomplete summary. Or they miss the most important fundamental work that they should have cited from 35 years ago. That makes me very frustrated, and then I do not trust them. Whereas if I get somebody who really works hard and I know that they're putting in those extra hours to come up with complete answers, hard work, I'm going to write them a much better letter of recommendation. I'm going to pick up the phone and say, if you don't hire this guy, you're crazy. I would do anything to hire this guy.
Yeah.
That's what you want.
Yes, yes, I understand. My second question, can you share a moment when mentorship played a pivotal role in your journey, and how important is mentorship for women in STEM?
Yeah, I mentioned to you, my friend Linda Strand said, work on a research project. That's an important question. So yeah, mentorship has been very important to me. And that's just been because I've been able to work with some great people,
Yeah.
and yeah, I think if you work with great people and you're working on important projects, then your trainees will learn what they need to learn.
Yes. You're right. Next, we will talk about future of pharmacogenomics and personalized medicine. In this context, my question, with advancement in artificial intelligence, big data, and the computational genomics, how do you see the future of pharmacogenomics shaping up?
Yeah, I think there probably will be some role for more computational approaches to have multi-gene pharmacogenetic tests. But I think that it's the simple stuff that we have to really get right first, and that's more actionable in the clinic. If we're talking about clinical implementation of pharmacogenetics,
Mm.
so you're looking for things that have very big effect sizes and they can be understandable to clinicians. So if there's a black box and a beautiful AI computational algorithm that says, I think that this patient is at a twofold higher risk of high blood pressure from that medicine, so you should give them half the dose. If nobody understands how that's working, I don't think they're very likely to implement it unless the studies that have supported that have just been replicated multiple times and done in very large populations. I think there's still a lot of work to do with simple 1 or 2 gene relationships.
I have a question. How do you envision genetic testing and precision medicine being used more broadly in everyday healthcare?
I mean, my hope for the future is that every baby gets their DNA done at birth, and there's some kind of computerized source of those results, and every clinician that would see that patient for the rest of their life has access to those results. But of course, that's I think we're still a long ways off from that. I think I'd like to see genetics be used just the same as they use body size.
Yes, you are right. What is the next big research question in pharmacogenomics and childhood leukemia that excites you?
Well, I've retired, so
Yes.
I'm not having to find my own questions anymore. Yeah, I think in leukemia we still need to do a good job of combining the germline and the somatically acquired, um, and to really get a feel for which is more important in determining freedom from relapse, the germline variation and the somatically acquired variation. So I think there still needs to be a nice big integrated study for that question.
Okay. The last part regarding advice. If you could give one piece of advice to young researchers passionate about pharmacogenomics, what would it be?
Yeah, I think I mean I still think it's a good area. I think it's that we need young people to specialize in this area. So I would say uh, don't give up hope, but also don't ignore all the other important variables that affect why medications work sometimes and not other times, right? Don't overemphasize genomics compared to everything else we need to continue to research.
Another question, as we celebrate International Women's Day, what does International Women's Day mean to you personally? And what message would you like to share with the next generation of women in STEM?
Yeah, I'd say keep working away at it, and don't focus on your gender. Don't worry
Yes,
about it.
you are right. Yes, 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 you are right. Lastly, how can we better support and celebrate the contributions of women in science?
I think we need to just keep encouraging. We need to recognize collaborative
Yes.
science. Sometimes the most important contributors to the projects might not always be the first author or the last author.
Mhm.
We need to be able to recognize that we need a lot of people in the middle to do those collaborations,
Yes.
um, and maybe not put so much emphasis when we're making promotion decisions for young people on independence, um, but more really try to reward scientists based on the importance of the research that they contribute to.
Yeah. Thank you so much, Dr. Relling, for sharing your invaluable insights and experiences with us today. Your pioneering work continues to inspire and transform the field of personalized medicine. It has been an absolute privilege to learn from you. As we celebrate International Women's Day, let's remember that every breakthrough, every discovery, every step forward in science is stronger with diverse voices. Let's continue championing inclusion, mentorship, and innovation in genomics and beyond. Thank you to everyone who joined us for today's session of the PAPERI Bright Minds series. Stay tuned for more sessions featuring exceptional leaders and innovators shaping the future of science, healthcare, and education. Make sure to follow PAPERI on social media for updates and on upcoming sessions featuring more exceptional leaders and innovators shaping the future of STEM. Stay curious, stay inspired, and see you next time. Thank you.